Oh, thank you. That works better. Um, so the online people can hear me. So yes, I'm going to go through some of our updates. Always no disclosures, although I know Jody is working on finding us some. So thank you, Jody. Um, so we'll go through, we were able to finally kind of pull together the initial descriptive statistics of who we're seeing on the VESPA team for the past 5 years. So I'll present that data today and then talk a little bit about some of the changes and challenges that we've had on the VESPA team and how we're thinking about elder abuse programs in general, and then some future projects that we're really excited about. So I think most of you are familiar with what VESPA does, but for those who may not be as familiar, VESPA is an inpatient consult team dedicated to the evaluation of elder abuse, neglect, and exploitation. And we have a host of activities. We're actually working now on developing a implementation blueprint and fidelity checklist, but these are kind of our core domains of activities. So we get activated anytime someone has concerns for abuse or neglect. So a patient or a family member often do report this, or the medical team is concerned about something, an injury, lab values, or just how the patient presented. Commonly, we get consulted when someone presents covered in feces. And so then we go in and try to do a pretty thorough abuse assessment. So there's a lot of injury and lab assessment, sometimes a lot of times talking to radiology, figuring out, are these fractures concerning? Could they be caused by other things? We do an extensive history, so a lot of chart digging in history from many family members. And then we do a lot of capacity and cognitive assessments pretty much throughout our evaluation, because a lot of our patients have had kind of incomplete assessments, either due to abusers being the ones providing most of the history or a lack of medical care. Once a patient is given a medical diagnosis of abuse, we're very clear we are not investigators. We don't say whether abuse or not is happening, but we say it's the most likely diagnosis or not. Then there's a lot of response and management. We complete our mandatory reporting in the state. We help with evidence collection. And disclosure to the family and patient what's going on, and then coordinating with the APS and law enforcement and other agencies to improve the care for these patients. And then after discharge, we are really the point people for the community when they need to figure out what happened in the hospital, what's been going on, and if it ever goes to trial, which doesn't usually go to trial, but if in the 3 cases it does, we would provide the testimony for it. And then throughout, we are also trying to provide trauma-informed care both to the patients and families, but also to providers, because we see a lot of moral distress and moral injury. So overall, we have seen 400, or over this time period, we've seen more than this. This was through September of last year. We saw 466 patients. That was representative of 531 consults. 423 patients were only seen once, and we had 43 patients who were seen more than once. In the range that we pulled, the range of encounters for the repeaters was 2 to 10. We have another one it's now like 2 to 15 because we have one case that's quite intractable, but that's an outlier. So a lot of our data here was collected for grant reporting purposes. So I'm working on getting our healthcare data, Health Compass data poll, sorry. And that's been an interesting challenge, but we're close, I think. So most of the patients we see are older adults. We sometimes see younger people who have an intellectual or developmental disability or early onset dementia. As with lots of geriatrics and also lots of abuse literature, we see primarily people who are both female assigned at birth and also identify as female, mostly straight. White is about 61% of our population. The African American or Black are the next most common, 24%. We only see about 13% who are identified as Hispanic, although how those are put into the medical record is always interesting as well. But a decent representation. One piece that we really see, though, is that we pretty much see English speakers. We see only 40 of our patients have been non-English speaking as their primary language, and that's mostly Spanish and Korean. I think there's a lot of reasons for this. We get consulted only if like the concern for abuse is raised. And as we know, people who don't speak English, providers spend overall less time getting the history from them. And I think families are more likely to stay in the room with a non-English speaker because of interpreting for the interpreter, especially with our older adults. So if they're on the phone, they usually can't hear, and families providing interpretation. It's sometimes harder to get those patients alone. But this is something our team has been trying to figure out how we can make sure that our language representation is more reflective of the community that we serve. We see some immigrants, not a ton. We also allow people to self-identify that. We don't ask about it anymore. And then veterans who land here at the U. Between cognitive impairment due to dementia and developmental delays, 56% of our patients have some cognitive impairment that impacts their capacity to make decisions. And the only thing that was just statistically significantly different between the people who were only seen once and repeat visits is there's a higher rate of cognitive impairment in the repeat visits. And that I think is often due to decision makers who are also the harmers choosing to take patients back home, which we have sometimes limited ability to intervene upon. And we have a fairly mobile population, so about 53% can walk independently or with a single gait aid. So of our 531 consults, we make reports to APS in about 67% and law enforcement in about 66%. The difference there is that sometimes we get consulted for caregiver neglect. We figure out it's actually self-neglect. We don't report self-neglect to law enforcement. We report all the other subtypes to law enforcement and then APS as well. So we only report self-neglect to APS. We have found, so that's about, I think we rule out abuse in a lot of cases too, which is one of the bigger functions of our team. In 10 of our cases, we found co-occurring child abuse. We're going to dig into this a little bit more with our child abuse team because in almost all of those cases, children were removed from the home. So while it's a rare event when co-occurring child abuse and elder abuse is found, it's usually pretty severe. And so I think there's more to look into there. I know it's a small end, but a very interesting and I think important end from a community safety perspective. And then we track services in categories that are defined by the Department of Justice because that's where we get our funding. So these are a little bit wonky, but we track them as based on the patients that are receiving the service and then how many times they can receive their service. So the biggest ones we do are advocacy and accompaniment because our social worker does a lot of that. And so, if law enforcement's interviewing a patient or APS, we will often provide accompaniment for that interview. And so we do that for most of our patients, especially, and also emotional support for most of our patients. Our criminal and civil justice interventions are the lowest, which makes sense. We're healthcare providers. But we do have a civil attorney who volunteers with us who helps with guardianship and conservatorship, Carl, who's amazing. So our most common abuse subtypes that we see are neglect followed by physical abuse, I think reflective of being in the hospital. This is different than the prevalence in the community, but I think the people who land in the hospital are sicker and more severely abused. And then financial, we don't see a ton of because we don't see just straight financial exploitation. So we will only see financial exploitation if there's other abuse types going along with it. After a couple years, we added escalation of violence as a category. Our team just felt there were some cases that had characteristics that were not well captured otherwise. So the big case that triggered this is we had a grandson who crushed his grandmother's car and had it put back in her driveway. And we're like, that's more than just emotional abuse. Something else is going on there. So we've added escalation of violence as a category. And it's pretty rare, but sometimes we do code for that. In terms of co-occurrence, we see mostly physical and emotional abuse like to co-occur, neglect and financial abuse often co-occur, and then sexual abuse co-occurs with physical abuse. Sexual abuse is kind of its own phenomenology. The people who engage in that, it's a little bit of a different phenomenon than the other types. And then violence escalation, we worry about mostly when we're seeing physical abuse or verbal emotional abuse. So there's been some changes to our model, mostly due to funding changes, but I think also some promising things to think about expansion. So we started a coaching model about a year ago. So low risk cases, our social workers and primary teams are now seeing with us giving advice. And the social workers have really liked it. It's allowing them to work at the top of their scope and really learn more about this. It also allows us to still be that conduit to the community and have contact with the cases, but not be as directly involved. Unfortunately, in January, we stopped seeing adults less than 70, and so have also been providing more of a coaching model to people less than 70 because the social workers have reached out asking for help, but we're not directly involved in those cases. But interestingly, we are still getting consults almost daily for people under 70. So the need is still very much there, and we're tracking those because there can be a nice control and like a silver lining way of a bad funding situation for the future to look at kind of the differences there. We've found some new fun ethical challenges this year, as we always do, on VESPA. So there's been a lot more discussion in this last year about removing MDPOAs versus having to go for full guardianship. I just had an interesting conversation with the county attorney at Denver, where they're also facing this on APS. So working on that, and Dr. Pang is working on a larger guardianship project. So we're trying to figure out how to navigate the guardianship system, find alternates to guardianship to help these patients get people who are really acting in their best interest. And then a new flavor of abuse that we've never really seen before, but we've had a couple cases in the last year of patients, decision makers trying to refuse analgesia at end of life. And so we've had to grapple with that ethically and legally. And that is not something I've seen described in the literature before. So the fun updates, those were kind of sad updates. The good updates. So we've been working on developing a system with Adams County courts to provide a virtual order of protection from the hospital. So orders of protection are commonly called restraining orders. Typically in the state of Colorado, someone has to go down to the courthouse physically. They cannot file virtually. They cannot file electronically for a civil order of protection. We reached out to the AG's office and we're like, this does not work for our patients who cannot physically get to a courthouse. And they realized that was a big equity issue. And so we are piloting with Adams County. We've developed a system where when we have a patient in the hospital, they have to have capacity to participate in the process. We can actually, our social worker will physically take the paperwork to the courthouse in Brighton, and then we will set up a virtual hearing in the hospital so that these patients can access orders of protection. And our big hope is that this will allow people to return to their homes because before we would have no way to get an abuser removed from the home setting. So very promising. We're going to start doing some like both qualitative and quantitative research on that once we have some cases running. And then we got a grant from the Administration of Community Living to develop an outpatient program for elder abuse intervention. We're working with our RISE colleagues. We're going to start enrolling patients in October. We just hired a social worker yesterday who's going to be joining our team. Her name is Laura. She'll be joining us all in June. We're very excited. And the goal is to start working with patients for about 6 months and really work on how do we reduce the risk of harm, reduce recurrent abuse, but then also meet the patient's goals and what really the patient wants. So I think will blend well with our geriatric priorities and how we practice medicine. And that will be rolling out in seniors clinic and in Anschutz's internal medicine clinic. You all will probably be contacted soon because we got a IRB approval to do interviews with providers to say what do you guys want this to look like? What are the outcomes you think are most important, et cetera. So Jillian will be emailing you all to participate if you would like to, which I hope you will, because it would be really helpful. So those are kind of the big updates. Sorry, there's not more exciting data, but we hopefully will have a lot more in a year from now to share.
We can take some questions if anyone has. I think this is coming on. I don't know. And then also, if anyone on Zoom has questions, happy to have you chat them in. Any questions?
Thanks, Elizabeth. Well, whenever I hear you talk, I always feel some anxiety about like what I don't know. And like one of the comments you made was, we don't diagnose abuse. And we can't do that. And it's one of my fears about these kinds of situations are, where am I going to step in it? What don't I know? Like, do you have like the top three or four things that you wish everybody just sort of knew about this topic? Because you know a lot.
Yeah.
Like, what are like the high yield things that I should know as someone who's not you?
Yeah. Um, Teets, you can weigh in too if you want. I think, yeah, I am very guarded with my language. So I tend to say in my notes, I'll say like high concern for physical abuse or high concern for neglect rather than like physical abuse, neglect. And in my assessment, I'm very clear, like there is like no other medical explanation for this, or like, neglect is the most likely, it's the unifying diagnosis, things like that. We tend to be like very deliberate because of the likelihood that this would go to court compared to our other cases. I think cynically, we've been I've realized that most of these cases are not going to go to court, so you can have a little bit less fear about that. It's pretty rare that things actually go to trial. Um, but I think that is one thing, is just like being really deliberate with our language of like, this is my diagnosis as a medical provider. I'm not saying 100% this is what happened. And I'll use language like, the patient report matches the injuries, therefore I have a high concern for physical abuse or something like that. Um, I think the other big high yield things is that like um, you can direct things a lot more than people think. So like when you're calling in reports to police and things, like you can recommend like places where they interview or reach out to this person first. I think we get very nervous when we have to call the cops, right? Like that's not a normal thing people do. I call the cops like, a couple times a week. And so I'm much more comfortable with it. But I think that they take our opinions very highly. And so if you're like, I'm worried that if you show up in uniforms, this is going to escalate the situation, they respect that. So I've been a little bit more directive of like, I think this is what this family needs, or this what this patient needs, with them as I've continued to practice. And then with APS, I think it's a little bit of a challenge because they interpret the laws differently across counties. But when I'm calling into APS, I'm like, I am a protective service. I'm this person's primary care doctor. And I use that language very explicitly. So I think those are some of the higher yield things. I don't know. Teets, do you have other things?
As an example of how our team always disagrees. I mean, I agree with everything that you're saying, and I think our team's been very thoughtful because in the child abuse world, they kind of got a lot of lessons learned about not being overly zealous and not being seen as investigators and not being seen as police. And so our team has been very thoughtful and intentional about that, which I think is good. For the average provider, only 1 in 24 cases of abuse are ever acknowledged or recognized. And so I guess I would say, like, if you are trying to do right by the
Yeah.
patient, at the end of the day, like, you're pretty well protected. And so I'm not sure that I would actually, for the average person, get so worried about that.
Yeah.
I think our team staffs all of our cases together and thinks through things. So don't do things in isolation. If you have concerns, reach out to other people, like ask for other advice, ask for opinions. But, thinking about abuse and caring about abuse is more than 99% of doctors are going to do. And so I think being thoughtful about it, trying to do right by the patient, being aware that it could happen is like a huge step forward. And so while there's all this nuance our team thinks about, I think actually for the average person, just having abuse on your differential, and then when you recognize it could be there, talking to colleagues and trying to figure out how to do the right thing, I think is like a huge, huge leap forward. So I guess, yes, we're very intentional. And I don't know that everybody else has
Yeah.
to have that level of intentionality, since they aren't the ones like who would be targeted by
Yeah.
some attorney that was upset.
Yeah, that's gonna be me. Good point. Yeah, I think the other thing is that, and I'm hoping with this outpatient program we can like demonstrate this. We partner with the harmer a lot. And so I think one thing that providers really worry about is like, if I say that there's abuse or neglect going on, I'm gonna like destroy the trust with that family and that relationship. But I think we've found ways to really partner with them and say, like, we're concerned things aren't going well, what we know from the literature is most of the harmers, especially the overwhelmed caregivers, they will like readily admit that things are not going well and they just want help. And so if we come from a place of like, I have to make this report for my license and we're going to help you and stay partnered with you. I think of it a lot the same as like end of life, right? Like the don't just drop end of life and then excuse yourself from the case. It's like, don't just drop abuse and excuse yourself. Like say like, I'm going to partner with you and like, we're going to work through this together. I think that goes a really long way. We've only had a handful of harmers that have actually been upset with our team. And we've only ever had we've had like over 700 consults where someone like stopped getting care because of an abuse report, but otherwise it's exceptionally rare when you really partner with people.
Thank you.
Okay.
All right, so we'll see if we can put Dan's up here. Excellent, that's great. Welcome, Dan. Should I read your bio? Okay.
All right, hey everybody, nice to see people here. So I'm going to talk about some of the work we do in the Colorado program for patient-centered decisions. And over the last couple of years, we've worked on 2 dementia projects, which many of you have given feedback on and helped with, and thank you for that. So I'm just going to give a little quick update. Let me just grab my phone real quick so I can watch the time. So there's a couple tools. This is our website that we've had since 2011, patientdecisionaid.org. We started it before the university had their rules, and so we're kind of continuing it because it's referenced in all kinds of places, and we've talked to them. We're sort of grandfathered in a way. I continue to worry that someday they're going to come down and crack down on us, but for now, we're continuing to maintain this. But these are all the decisions we've worked on. I've done a lot of stuff with the cardiovascular disease at the top, but if you look at the bottom here, there's a couple new ones, a dementia roadmap and an anti-amyloid therapy for Alzheimer's disease. And I'm going to talk do a little show and tell on these two. We're in the midst of pilots for both of these, so I don't have a lot of data to show you, but I'll at least give you an idea. So starting out with the dementia for roadmap, or a roadmap for dementia. This has been one of the hardest ones I've ever developed just because of the sheer volume of content. We've had it at up to 100 pages and we've gotten it down to like 34. We used AI for help. This is a great use of AI. I'm starting to think about how AI is overtaking what I've spent 20 years learning how to do in terms of making content, and now it can do it in minutes. So that's a whole separate existential problem. But it was very helpful. Like, hey, here's some content. Can you lower the literacy level down to the 8th grade or even the 5th grade? Can you give us 2 or 3 different ways to say this? Can you help me shorten this? And we found it very helpful, and it helped us speed up through this. So I won't go a lot of show and tell on this one because it is so long, but there's 4 sections here. Is kind of where we ended up. We had 2 panels of patients or 1 panel of patients and caregivers and 1 panel of sort of community experts involved with dementia. And we ended up with a section on where to begin, learn about dementia, sharing a diagnosis, health professional support, managing dementias, managing symptoms, managing legal matters, paying for care, what matters most, planning ahead, planning for changes, planning for late stages, safety considerations, communication and caregiver support, and then resources. And the resources, we have sort of 2 levels. There's a couple pages in the print version that are like national common resources, and then we're going to have more resources online that people can contextualize and localize. Because one of the challenges with dementia and giving resources is they are so geographically bound as terms of what's available. One of the people on our panel is in Durango, and she constantly talks about how different things are in Durango. And this was funded by the Anschutz Acceleration Initiative, that grant we got a couple years ago to try and develop and test more rapidly and rigorously, where instead of taking an idea and spending years studying it, doing an NIH R01, can we develop, can we pilot it, and can we get it out? So we're about 1.5 years into this, and we've developed it. We have it on our website. It's disseminatable, and we're piloting it right now. Now, I'll talk about our pilots. So we're doing 2 separate pilots. We're doing one with patient and caregivers and one with the community. This whole Anxious Acceleration Initiative is an implementation science grant, really, and using those methods. And so we want to get into the community. In contrast to a lot of the other decision aids I've developed around a single decision, the roadmap is trying to fit a different niche. Most of the decisions we make are not little single decisions. It's multiple decisions in the setting of chronic illness. And so how can we support patients and caregivers doing that? That's the idea behind our roadmap. And so we're just playing with this concept. We've written a paper about it. Hillary helped us. I think Hillary helped maybe even coin the term or got us thinking about it. But this is us trying to play with it and study it and see if this is something that could help people. But we started out, let's do a community pilot. We've made this thing. We don't know who wants to use it. So let's just go into the community and see who wants to use it. So we're going to like rec center with senior programs. I gave a talk at Cavode last Friday. Channing went down to Colorado or Pueblo and gave a talk to like 8 organizations. And then we're sharing it with them. We're kind of chumming the waters. Here's a stack of 50 of them. Do you want to hand them out? And then we're going to interview those organizations, say, hey, did you hand them out? Did it help? Did you find it useful? We're working with the Colorado Department of Public Health and looking for area agencies on aging and seeing if we can share with them and reaching out to some listservs. It's a small pilot. We only have a few months to do it, but we're just trying to figure out, we've made this thing. We get a lot of feedback from patients and caregivers that this is great, this is helpful, but how do we actually get it used? So that's what we're kind of doing now with the community pilot. But then we thought to ourselves, that's a really fun pilot. That's the pilot we should do. But if I'm going to write a follow-up grant to the NIH, I need to give them something traditional. So then we decided to add a separate pilot and just enroll 100 patients using the new recruit tools through UC Health, not even going through necessarily a clinic, and just handing it to a patient caregiver and getting feedback in a more traditional pilot trial kind of way, so that we can have both of these as our pilot data for our next grant. Because I don't know where to use it. We could work with, obviously, the seniors clinic, say, hey, here's this tool. I always thought in clinic it'd be that there were those broken record speeches when you have a patient. And so a lot of what's in here are those broken record speeches, so that you could hand something to a patient. They could go home and read and study on their own time and hopefully enhance their understanding of things. So the patient caregiver pilot is 100 people using Recruit, and the purpose is really to understand the impact on does it help them feel more prepared? What about it was useful? What might they change? Actually, through this, there's really not a great measure of sort of preparedness for chronic illness. There's a lot of decision-making measures for single decisions that all have their own weaknesses, but there's very little. There's a couple of measures for like caregiver preparedness for caring for someone with chronic illness, but there aren't great measures. So we actually wrote a bunch of new questions around this. And if we can get enough patients, we may actually do some psychometric work, and that might be sort of a separate thing we do. Laura Scherer on our team knows how to do psychometrics, so we've got somebody who can do that. And then the community pilot, this is where we're recruiting up to 50 organizations. And this is where I said, we're just going out and doing a canvassing thing. We did this with our LVAD work. It's like social marketing methods. It's the same methods that like a drug company uses when they reach out to you and invite you to dinner. We're kind of doing some of that, cold calls and trying to get people on the phone. It's how you disseminate things. So we're using those kinds of methods for this community pilot. So that's the roadmap. It's available on our website now. If people want it in the seniors clinic, I can bring a stack of these over and you guys can play with them if you like them. A lot of you gave feedback on them. I just haven't, you're on my list. I just haven't gotten there yet. So Sarah, maybe I'll bug you and bring a stack over at some point. Then this other tool, this was a separate grant we wrote at the same time as the Dean's grant. And it was just an R21 for these new anti-amyloid therapy drugs. And this one's been fun. So I'm going to show a little bit of this one too. So this is also on the website, even though we're still piloting it. We're just now piloting it. We only have 7 patients enrolled. Just met with Tara Carlisle yesterday about brainstorming ways to increase enrollment. Really want to get people before they go talk to the doc, but that's always hard in the outpatient setting. To really know when, and we've called people that are referred to her and they have no idea why they're referred to her, and so they don't think they're eligible. So that's been one of our challenges. But anyway, I'm just going to go through a couple of the pages. So one of the first things we talk about is, does the anti-amyloid therapy reduce the amount of amyloid in the brain? And we show it does. Before, after, there's a big decrease in amyloid. Without, there isn't. And we've had feedback. A lot of actually some of the feedback from you all in the seniors clinic was like, oh, that could be overly biasing. That could sell this drug. And you're absolutely right. And we elected to keep it because this is what we heard from a lot of patients that they saw. They go on the Alzheimer's Association and they see these pictures of these PET scans. And so if they go on the web, that's our competition. They get the information that it reduces amyloid. So I'm just throwing them that bone. Yes, this thing works. It lowers amyloid in the brain. It does that. And it's cool. And those pictures are cool. There's no way around those PET scan images are cool. And then the next page is this, but does it actually make you better? And we get the flip feedback that this is, some people are like, oh, in the New England Journal papers, they showed the relative risk. They did, or they showed the change in symptoms, the change in score, so it looked bigger. So we put an absolute scale over on the left and show the absolute difference. And we hear from people like, oh, I thought the paper showed a much bigger difference. Like, no, this is the difference. It's like, a decimal. It's like a less than a point on this scale. And over time, it doesn't do much. And so the reason we chose to keep the amyloid is that's what people are getting. And also then it helps maybe make this more trustworthy too, that we're not trying to hide anything or undersell it. So those are those design decisions we made. Some other design decisions. This is the classic decision aid icon array. There's some science that people understand data better this way. I'm not sure how important numbers are in this decision, to be honest. But I'm trying to use state-of-the-art ways to communicate numbers, and this is sort of the risk of brain swelling and the risk of brain bleeding. And we have, the dark person is a person who has symptoms. This is not ideal, but we're trying to get a lot of information on one graph rather than have a whole bunch of icon arrays around this. Oh, and that gets into another challenge. You can't really do an icon array with a continuous scale, and there's not a lot of science on what's the best way to kind of present an improvement in quality of life or a reduction in symptoms. It's easy when you talk about side effect, yes, no. Mortality, yes, no. These icon arrays work great for that. They don't work so great for like an improvement on a scale over 18 months. So we struggle with that. And then another thing that we put in here is the different infusion schedules. About halfway through this project, donanemab got approved, and then all the people we're talking to said, oh, you got to include that too. So we went back and redesigned. But the big difference between lecanemab and donanemab is the infusion schedule. Donanemab is quite a bit easier. It's only once a month instead of twice a month, which makes a big difference for a lot of people. Even though donanemab may have higher side effects, at least in some of the trials. But this one's been interesting because there's a lot of challenges. Big challenge in explaining the biology. We have a page at the front of it that's pretty wonky on what tau and what amyloid is. All of the neurology people wanted that in there because they are already trying to explain it to patients. And so we decided we had to keep it because they're going to do it anyways. So let's do it and do it as simply as possible for at least the subset of people who want it. Showing that it reduces amyloid, I already talked that, and then showing that it only gives a small benefit. That was one of the hardest things to get right. And then an interesting one for me that I didn't think about is because this is such a new therapy, the data changes every few months. Oh, this new study came out. We need to change the language. And we had this a little bit with our LVAD decision aid, and Larry Allen kind of stays on top of the data, so we're always tweaking it. But this one's been harder, like a new drug gets approved. Oh, we got 3-year data now. Or the 3-year data was just presented at the conference, but it's not peer reviewed. So what do we say? It's just, when I worked with defibrillators, it had been around for 10 years. So some of the data was a little more standard. I didn't have as much sort of changing data as we were designing. And I always say decision aids should be living documents. You should kind of keep them alive with the data, but that's been a challenge here. The infusion schedule was really hard to explain. The burdens, like one of the big downsides here is just the burdens, multiple visits. Tara in her clinic here tells people that they really shouldn't travel too much while they're doing the therapy, which if you have dementia and you're kind of in the early phase, boy, that's a good time to travel, because it's going to get harder. And then you do this therapy and then for 1.5 years, you can't travel. That could be a problematic for some people. And then obviously the thing that got me excited about this was just the cost. $26,000 a year for a less than point improvement on a scale. seems pretty marginal to me. But this is the first mechanistically driven therapy that actually is doing something with Alzheimer's. Like, I can't argue that. It is real. It's just very small. So is the cost worth it? But so talking about the costs and talking about societal costs versus individual costs, and it's a small piece of our decision aid, just a little paragraph, so people are prepared. But it was a big piece of our development discussions, especially with our patient and caregiver panels. These are obviously really important topics. So where we're going, we're in the process of doing a pilot with this. We're approved for 100 people. We're shooting for just about 20 people in the throes of this decision over the next few months, and I can present more. And these are our teams. Sunny was helpful, especially with the anti-amyloid decision aid. Tara's been wonderful to work with. I went and watched her for a half day in clinic, just counsel patients. And she's really good. I would feel comfortable sending them to her. She spends a long time with people and she does not push these drugs. And I think she even gets pushback from the hospital, like, hey, how come more of these people aren't getting the drug? Because she's just honest with them. And she'll do it if they want, which I think is the right approach. So I've really enjoyed getting to know her and work with her on this. But also just a great team of folks and some of our patient and caregivers. So with that, I'll stop, see if people have any questions, and give Hillary some time for her talk.
This is relevant to both of these projects. They both involve living documents, and I'm just curious how you approach that challenge. Like the ever-changing resources in dementia care, the constantly changing data with the anti-amyloid. Like, how do you like put that on your to-do list even?
I mean, it's really hard. It's easy when we have sort of funding for grants. It's easy when, like the LVAD one, we've got a whole team where there's Larry and Colleen and the heart failure team that just are constantly using it. It's really hard. Some of the ones we made, like the aortic stenosis and the TAVR one, we made that 10 years ago. The data's changed a lot. It's getting used in a PCORI grant. So this last week, I was on 2 meetings about updating that and talking to the ACC because they own it, even though we developed it, about their graphic designers making tweaks. It's a pain. It's one of the International Patient Decision Aid Standard guideline criteria to put date last updated and who was the development team and what conflicts of interest did they have. So when you get one of these, you can look and see when was this last updated. But Jacob, that is like one of the hardest pieces. And I don't want to run a business and there's not a big profit. So I couldn't just keep asking for money. That's, I guess, what we do in medical research these days. So I kind of fund it out of some of the Accords funds is what I use to pay to keep our website going. We have some of those ACC contracts. We have in a fund that we can kind of use year to year. It doesn't expire. So we'll use that when we can't find other money to kind of update things. We also kind of pay ourselves to make sure we get Spanish versions. We're not quite there on these yet. We speak English, so it's easy to develop in English. But then once we get it there, then we try to make a Spanish version at least, which is important. But yeah, that is a wicked problem.
Thanks, Dan. I got one question. Are you attempting to pilot or test any of these other than coronary artery disease roadmap? Because the population is different.
Yeah, no, not yet. I'd like to. And, part of the reason to do these pilots, we've got them developed. Now we're doing the pilots and then see where we can go with the next grant. I'd love to do these in the VA. I thought of these as a potential clinical innovation in a future year or two. It's just a little easier to rapidly iterate outside the VA. So we've kind of done that this way. He mentioned the CAD roadmap because there's a coronary artery disease roadmap that we have actually piloted in the VA. That actually we got great feedback from patients and even a significant improvement in their understanding of CAD. So we're in the process of going back and presenting that to the primary care docs at the VA to see, hey, do you want to kind of take this and run with it? But we'll see. That's the implementation piece. But yeah, more to come, and I should.
And
especially with the other hat they wear.
Idea for a future one. GLPs are really hot right now for weight loss, and we don't know a lot about them. And I think patients, in terms of side effects, perhaps, and I think patients would benefit from understanding and having decision aids on high dose GLPs for weight loss.
Oh, I think that's great. Actually, there's a guy, David Arterburn, he was Group Health. I think it's Kaiser Washington now, but he does a lot of obesity decision aids and is adding GLP-1s. It started with like bariatric surgeries and those kinds of options, which it's hard to do just GLP without the other obesity options. And so I think he's running with that, but I totally agree. As someone who's on a GLP-1, they are downsides for sure. All right, thanks, Hillary.
Okay, so we have some themes, and one of the reasons I love, Dan, that you said yes, is that I get to hear updates related to your work, and there's probably even crossover. So part of also why we like to have these highlights is that we hope to stimulate discussion, which we're already doing, but also collaboration moving forward. So I'm going to talk about updates on the guide model in clinics and a little bit communities, but mostly clinic. So this was sort of represented by Dan's work in terms of a roadmap, but there is a strong evidence base for comprehensive dementia care. This paper was published by the Alzheimer's Association and other colleagues, where they gathered together what are the components that really make up person-centered care. We at Seniors Clinic and the VA in memory disorders care have been doing this for a long time. And the goal has been, how could this be packaged in models and disseminated across the country? So just a little bit of history in terms of our experience with dementia care models. Some of you will remember Living with Dementia, which Bennett Parnes heard about first at an AGS plenary where Kate Posehn was talking about care ecosystem. And Bennett said, let's start this. We have comprehensive primary care first money. Let's just do this. So we started Living with Dementia with those quality improvement funds, and then also had the chance to participate in a care ecosystem R01. Several of our patients in Seniors Clinic have been able to be enrolled in some of these models. You can see that we've had over 175 individuals involved in Living with Dementia. Thomas, Hannah, others were involved in some of the early evaluation where we looked at the first 57 or so patients. They read through notes and did qualitative coding to find out what were the topics that the care navigators were talking about with patients and caregivers who were involved in these longitudinal dementia care navigation calls. So just showing here that we really saw a lot of focus on care partner well-being, especially emotional support, behavioral management, really talking about and supporting communication strategies, and then specific referral assistance, including referrals to social work and others. So a mix of the things that are on the dementia roadmap, but then also were happening every time that the phone calls were happening. One of the outcomes we've been looking at is caregiver self-efficacy, because this has really been demonstrated across several of the evidence-based models to be one of the things that dementia care navigation is improving. So perhaps you've heard about the D-Care study, which didn't change neuropsychiatric symptoms. Perhaps you've heard about the In Peace study, which focused on dementia palliative care, which also did not change neuropsychiatric symptoms, but did have signals for caregiver self-efficacy. Actually, In Peace also had improvement in the number of emergency room visits, sort of trending toward hopefully improving days at home. So there's this large evidence base for dementia care models. With that, lots of people have been advocating for a model that CMS could test. So that's what GUIDE is, Guiding an Improved Dementia Experience, put out by the Innovation Center, really focusing on coordinated and comprehensive care management services. There was a call for applications. Programs were able to start in 2024, and the Medicare reimbursement will continue for 8 years to 2032, really focusing on having dementia care at the center with care planning, education and support, and a lot of linkage and coordination with health systems, community, as well as state and local resources. So that's what the model is. Here locally, this is what motivates us as our GUIDE team. We really want to continue to provide excellent dementia care coordination, support family care partners. We also want to hopefully raise all boats, enhance dementia care across the health system by partnering with Elizabeth with VESPA team, partnering with care management across the system. And then we also hope to partner in the community, so especially with CDPHE and area agencies on aging and adult day centers to strengthen clinical and community partnerships. So some of the nuts and bolts of GUIDE, who can join? You must have a clinical diagnosis of dementia, must have traditional Medicare, parts A and B. I mentioned this just because word about GUIDE is still getting out into the community. Many people don't know about it. And so if you know someone who's living with dementia and they have Medicare fee for service, they might be appropriate for GUIDE. Depends a little bit on where they live. What are the goals of GUIDE? So this won't surprise any of us. Medicare cares about improving quality of life for people living with dementia, delaying avoidable long-term nursing home care, enabling people to live at home through end of life, and enhanced support for caregivers. It's amazing that they've added in the enhanced support for caregivers. Big picture, this is the first time Medicare has provided a reimbursement for anything that involves a caregiver. And therefore, sort of nationally, we're thinking about there's a lot riding on GUIDE, some of us think, in that if we can't do it for dementia, we may not have opportunity to do it for other serious illnesses or other conditions. So we really would like to be all in having this natural experiment have high fidelity to the intervention. So I'm showing you here what's involved in the intervention. It's team-based, has a dementia care navigator. Different programs have different people doing this role. And then there are several care delivery requirements, 9 of them in fact. This is also the first time Medicare has covered a respite benefit. The VA is often and always far ahead in terms of long-term services and support. VA has had a respite benefit for a long time. Within GUIDE, individuals of moderate severity with a caregiver have access to a respite benefit. This is also what the care navigation looks like in terms of the monthly outreach calls or connection between our navigator and a care partner. We're talking about a lot of these types of things. So of course, there's a lot of consistency, trying to take the theoretical models of what is great dementia care and then have it happen on a monthly basis. So nationally, what does GUIDE look like? We're finishing up year 2. There were 390 initial healthcare organizations who started. There's been some attrition because with all models, it's actually hard to get started. And we are going to be seeing how well also programs can sustain. So there are currently 321 participants based on Medicare's website. And there was a recent published paper that looked at the 235 unique organizations where they could tell that it was the same company, even if they were perhaps operating under different names, different GUIDE applications. And you can see that 30% are part of a health system like us, 30% operate in multiple states, 16% are virtual care only. So think, BetterHelp.com, like just virtual only. So there are dementia care companies that are in this space and have ability to scale. So I think that there are likely adaptations and trade-offs that we can learn from in this diversity of the different programs. 47% are not-for-profit ownership. Here in Colorado, there are currently 5 programs. There were 6, so TRUE is no longer enrolling individuals as of July. They are continuing services until the end of June. For any of you who might have patients who have been involved in that program, feel free to reach out to me and we can help with coordination and a smooth transition. But these are the other programs that are available in Colorado. We meet every other month as a Colorado GUIDE Learning Collaborative. So really trying to develop a space where we can share knowledge, seek to be well coordinated. I know Dr. Yasui is joining us by Zoom. She is one of the medical directors with Always Supportive Care. And it's really been helpful to be able to share best practices so that we can have increased reach, especially across rural Colorado. What does the program look like here at CU Medicine and UC Health? There are 2 of us who are the dementia specialists, Dr. Hildreth, who's online, and myself. There is about 2.0 FTE of care navigators who are members of our division of geriatrics. So this is split across Adrian Tatro, Evie Romeo, and Jessica Cassidy. terrific support from our social workers, both here at UC Health and then also through neurology, Kavod, across a couple of key clinics. And we're a big team, so a number of roles supported by Alex Marcus, Sherry Bailey, Kathleen Resman, and Lisa Schilling's group through Office of Value-Based Performance. We also have contracted with home safety and respite care partners. So you can get a sense that this is like sort of a big thing to navigate, and we hope to do it smoothly so that the experience of patients and caregivers happens well. And we've been learning a lot as we've been going. This gives you a little bit of a sense of where we started and where we are now. So July 24 was when we were first able to enroll individuals specifically in GUIDE, and they were approved by Medicare. And these data are through the end of December. So we've had 144 ever enrolled, and in December, the census was 108, including so far 24 who are enrolled for more than 12 months. So I think, similar to maybe some other themes of pragmatic research or clinical innovation, we're learning as we go, including learning sort of what is our ability to enroll people per month, and also what is our attrition, where individuals are transferring to hospice or long-term care or want to step away from our GUIDE program. So there's a lot of flexibility that we're needing to sort of adjust in the moment, depending on what's coming up. This slide, I'll just let you sort of reflect on it. This is why we do what we do. We can tell from care partners, the feedback that we get, that it's helpful to them, like really helping in a whole person and whole family way. One of the recent wins was that a care partner shared a poem that they had written about the caregiving experience, made a point to share that with their guide navigator, just sort of being able to sort of feel heard, understood, related to the dementia experience, and even a creative outlet, and then wanting to share that and have it be witnessed by other people. In many ways, our care navigators describe themselves as being a friend on the inside or a mentor, and I think that's helpful. Just briefly about clinical and community research resources, Dr. Peng, Thais Protasio, Ilian Mino, and others worked on updating our resource guide, local here to Denver Metro, where we actually continued what initially other internal medicine residents had started of finding out what resources here in Denver are able to offer bilingual and Spanish services, and then packaging them. So Jacob, to your question of how do we invest in updating these resources, we try to do it yearly. It's hard to do it more frequently than that. And so just doing the best we can. This is available on Colorado Care Planning, or please feel free to reach out. We have both this one as well as the UC Health specific dementia resource guide. We share these out with our guide participants. We're also sharing out the dementia roadmap and really trying to be able to make accessible more resources to individuals. So I have 3 slides, just what's on the horizon for us. So specific to GUIDE, we have 2 different measures that we've done work to have them integrated into UC Health. So we are asking the caregiver rating of dementia care quality and the caregiver satisfaction with care. These were part of David Rubin's large PCORI study to try to assess caregiver perspectives of dementia care. So we're asking these at the annual visit and using them both for input from the care navigator to get this sense from the care partner of how are things currently, but then we'll also be able to compare them over time. We're looking at model fidelity. We're always investing in community outreach and engagement partnerships, including our What to Know Wednesday monthly seminar. We're also hoping to have a November event, more to come on that, specifically for caregivers and persons living with dementia. And we're always thinking about sustainability planning. From a research perspective, I'm submitting an R01 to look at value, cost, and sustainment for GUIDE. Along the lines of decision aids, just new this week, our team is going to start. So Bree Betcher, Dan Matlack, and I have opportunity to perhaps take next steps towards funding related to developing an Alzheimer's disease biomarker decision aid in primary care. So before you can be thinking about an anti-amyloid therapy, you need to have confirmation that the reason for your dementia is Alzheimer's disease. And then it also gets more complex. Even if you had Alzheimer's disease by biomarker, is that actually the reason for the symptoms that might be amenable to the amyloid therapy? So more to come if we have opportunity to be funded by the NIH for this type of decision aid. And then also what I learned about last week is there's availability of funds through the Rural Health Transformation Program. And specifically, our Alzheimer's Disease Action Coalition through CDPHE is interested in training for rural clinicians to conduct cognitive assessments and increase dementia detection and diagnosis. So we may be able to receive the contract to coordinate this work across the state, as well as in partnership with some of our practice-based research network colleagues. So more to come, hopefully, on that as well. And if anyone has interest in any of these things, would love to hear from you so that we can hopefully collaborate. And with that, I'm happy to take any questions. Oh, thanks.
Thanks, Hillary. I had a question. You sort of alluded to, we want to sort of demonstrate that caregiver support helps these programs and these patients. Do you have a sense, or is there like a defined outline of what the CMS is looking for in terms of outcomes? And like, is it related to placement, or what are the specific outcomes? Just, I'm curious.
Yeah, so CMS is absolutely looking at if individuals are admitted to long-term care nursing home placement, because really trying to look across both Medicare and Medicaid, what's needing to be paid from the CMS perspective. They are, from a caregiver perspective, assessing Zerit burden. So the 22-item Zerit burden. That's where I'm really motivated, as with several of our colleagues nationally, to do a deeper dive of caregiver benefit and experience, because the Zerit burden is just one measure. And as Dan alluded to, it's the caregiving experience is somewhat difficult to measure, and we have to be really thoughtful about what we're measuring to say to see benefit, I think, in different ways of the program. Fabulous. Well, great to see everyone officially for grand rounds, and we will take some stretch break and switch to the other Zoom for division meeting. But really, thanks all for participating.